Good morning, ladies and gentlemen. I'm Dr. Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about endocarditis. Endocarditis, actually, we will talk about infective endocarditis, and at the end, maybe I will put some words about just non-infective endocarditis. So, what is infective endocarditis? Infective endocarditis is obviously infection of the endocardium, usually with bacteria, commonly streptococci or staphylococci, or fungi. Streptococci, staphylococci, or fungi. Or in English, streptococci or staphylococci. So, it may cause fever, heart murmurs, petechia, anemia, embolic pneumonia, and endocardial vegetations. So, vegetations may result in valvular incompetence or obstruction, myocardial abscess, or mycotic aneurysm. Diagnosis requires demonstration of microorganisms in blood and usually echocardiography. Treatment consists of prolonged antimicrobial treatment and sometimes surgery. Endocarditis usually refers to infection of the endocardium. That is why we call it infective endocarditis. This term also includes endocarditis, non-infective endocarditis, in which sterile platelet and fibrin thrombi form on cardiac valves and adjacent endocardium. Non-infective endocarditis, actually our topic today, sometimes leads to infective endocarditis. Sometimes non-infective leads to infective endocarditis. So let's talk about infective, today's topic. Both can result in embolization and impaired cardiac function, but actually non-infective endocarditis I want to put, if God wants, of course, at the end of this lecture, maybe second lecture, not maybe second lecture. The diagnosis of infective endocarditis is usually based on a constellation of clinical findings rather than a single definitive test result. Infective endocarditis can occur at any age. Men are affected about twice as often as women. Intravenous drug abusers, intra-immunocompromised patients, and patients with prosthetic heart valves and other intracardiac devices are at the highest risk. So we've got a very beautiful osmosis presentation. I wanted to put this presentation just at the end of this lecture. At the end of this lecture, yes. About etiology of infective endocarditis. The normal heart is relatively resistant to infection. Bacterial and fungi do not easily adhere to the endocardial surface, and constant blood flow helps prevent them from settling on endocardial structures. Constant blood flow. Thus, two factors are typically required for endocarditis. First, predisposing abnormality of the endocardium anatomically. Second, microorganisms in the bloodstream, so bacteremia, that exist always, but not always sepsis. Rarely massive bacteremia or particularly virulent microorganisms cause endocarditis on normal valves, but it's very, very rare. Okay? So that is why we will now talk about endocardial factors. Endocarditis usually involves the heart valves. Major predisposing factors are congenital heart defects, rheumatic valvular disease, bicuspid or calcific aortic valves, mitral valve prolapse, hypertrophic cardiomyopathy, and a prior endocarditis. Prosthetic valves and other intracardiac devices are a particular risk. Occasionally, mural thrombi, ventricular septal defects, and patent ductus arteriosus sites become infected. The actual nidus for infection, nidus for infection, is usually a sterile fibrin platelet vegetation formed when damaged endothelial cells release tissue factor. Infective endocarditis occurs more on the left side. So once again, infective endocarditis or endocarditis, more correct, I suppose. Infective endocarditis occurs more often on the left side, for example, mitral or aortic valve. About 10 to 20% cases are right-sided, tricuspid or pulmonic valve. Okay? Tricuspid or pulmonic valve. Intravenous drug abusers have a much higher incidence of right-sided endocarditis, about 30 to 70%. So about microorganisms that infect the endocardium may originate from distant infected sites, for example, cutaneous abscesses, inflamed or infected gums. Yeah, it happens. The urinary tract infection, very common. Or have obvious portals of entry, such as central venous catheter or a drug injection site. Almost any implanted foreign material, for example, ventricular or peritoneal shunt prosthetic device, is at risk of bacterial colonization, thus becoming a source of bacteremia, and hence endocarditis. So bacteremia and hence endocarditis. Endocarditis also may result from asymptomatic bacteremia, such as typically occurs during invasive dental, medical, or surgical procedures. Even not massive. Even toothbrushing and chewing can cause bacteremia, usually due to viridans, streptococci. Viridans streptococci in patients with what? With gingivitis. In patients? Yes, with gingivitis. Causative microorganisms vary by site or infection, source of bacteremia, and host risk factors, for example, intravenous drug abuse, but overall streptococci and Staphylococcus aureus cause 18 to 90% of cases. Okay? So streptococci and Staphylococcus aureus. Enterococci, gram-negative bacilli, FESC organisms, so the Haemophilus species, Actinobacillus actinomycetometans, Acetinomycetonocomitans, Cardiobacterium hominis, so I'm sorry for my pronunciation, Elkenella controdans and Kingella kinge, and fungi cause most of the rest. So the disease develops in 3 stages. Bacteremia, microorganisms are present in blood, but this is not a sign of disease. But bacteremia also, almost all of us got it, bacteremia. Adhesion. The microorganism adheres to abnormal or damaged endothelium via surface adhesions. And colonization. So proliferation of the organisms together with inflammation leading to a mature vegetation. Many of the causative microorganisms produce polysaccharide biofilms that shield them from the most immune defenses and impede antibiotic penetration. This due to these biofilms. About pathophysiology of infective endocarditis. So endocarditis. We talk about pathophysiology. And pathophysiology of infective endocarditis has local and systemic consequences. So let's talk about local and systemic consequences of pathophysiology of endocarditis. Local and systemic consequences. So local consequences. Okay, local consequences of infective endocarditis include myocardial abscess with tissue destruction, sometimes conduction system abnormalities, usually with low septal abscesses, sudden severe valvular regurgitation causing heart failure and death, usually to mitral or aortic valve lesions, aortitis due to contagious spread of infection. Prosthetic valve infections are particularly likely to involve valve ring abscesses, obstructing vegetations, myocardial abscesses, and mycotic aneurysms manifested by valve obstruction, dehiscence, and conduction disturbances. About systemic consequences. Systemic consequences of endocarditis are primarily due to embolization of infected material from the heart valve, immune-mediated phenomena primarily in chronic infection. Right-sided lesions typically produce septic pulmonary emboli, which may result in pulmonary infarction, pneumonia, or emphysema. Left-sided lesions may embolize to any tissue, particularly the kidneys, spleen, and central nervous system. Mycotic aneurysms can form in any major artery. Cutaneous and retinal emboli, are common. Retinal. Okay, diffuse glomerulonephritis may result from immune complex deposition. Okay, about classification of infective endocarditis. Infective endocarditis may have an indolent. So infective endocarditis may have an indolent subacute course or a more acute fulminant course with greater potential for rapid decompensation. So subacute bacterial endocarditis, although aggressive, usually develops insidiously and progresses slowly, that is over weeks to months. Often no source of infection or portal of entry is evident. Subacute form is caused most commonly by streptococci, especially viridans, microaerophilic, anaerobic, and non-enterococcal group D streptococci and enterococci, and less commonly by Streptococcus aureus, Staphylococcus epidermidis, Gernella morbillorum, Abitrophia defectiva, formerly Streptococcus defectivus, Granulecatella species, and Fastoideus haemophilus species. Subacute form often develops on abnormal valves after asymptomatic bacteremia due to periodontal, gastrointestinal, or genitourinary infections. So acute bacterial endocarditis usually develops abruptly and progresses rapidly, that is, over days. A source of infection or portal of entry is often evident. When bacteria are virulent or virulent or bacterial exposure is massive, acute bacterial endocarditis can affect normal valves. It's usually caused by Streptococcus aureus, group A hemolytic streptococci, pneumococci, or gonococci. Prosthetic valvular endocarditis, prosthetic, develops in 2 to 3% of patients within 1 year after valve replacement, and in 0.5% year thereafter. It's more common after aortic than after mitral valve replacement and affects mechanical and bioprosthetic valves equally. Early onset infections, less than 2 months after surgery, are caused mainly by contamination during surgery with antimicrobial resistant bacteria, for example, Streptococcus epidermidis, diphtheroids, coliform bacilli, Candida species, Aspergillus species. Actually species. Right? I can't pronounce species. Not my day today. So late onset infections are caused mainly by contamination with low virulence organisms during surgery or by transient asymptomatic bacteremias, most often with streptococci epidermidis, diphtheroids, and fastidious gram-negative bacilli, Haemophilus species, Actinobacillus actinomycetomectominans. Yes, it's not my day, absolutely. So Actinobacillus actinomycet and Cardiobacterium hominis. So symptoms and signs of infective endocarditis. Symptoms and signs vary based on the classification but are not specific. For example, symptoms and signs of infective endocarditis, subacute endocarditis. Initially, symptoms of subacute bacterial endocarditis are vague, low-grade fever, low-grade less than 39 degrees Celsius, night sweats, fatigability, malaise, and weight loss. Chills and arthralgias may occur. Symptoms and signs of valvular insufficiency may be a first clue. Initially, less than 50% of patients have fever or a murmur, but eventually almost all develop both. Physical examination may be normal or include pallor, fever, change in a pre-existing murmur or development of a new regurgitant murmur, and tachycardia. Retinal emboli can cause round or oval hemorrhagic retinal lesions with small white centers, Roth spots. Cutaneous manifestation include petechiae on the upper trunk, conjunctiva, mucous membranes, and distal extremities. Painful erythematosus subcutaneous nodules on the tips of digits, Osler nodules. Non-tender hemorrhagic mascules on the pulse or zoles, January lesions, and splinter hemorrhage under the nails. About 35% of patients have central nervous system effects, including transient ischemic attack, stroke, toxic encephalopathy, and if a myocardic central nervous system aneurysm ruptures, CNS, nervous ruptures, brain abscess, and subarachnoid hemorrhage. Renal emboli may cause flank pain and rarely gross hematuria. Splank emboli may cause left upper quadrant pain. Prolonged infection may cause splenomegaly or clubbing or fingers and toes. So, acute bacterial endocarditis and prosthetic valvular endocarditis. Symptoms and signs of acute bacterial endocarditis and prosthetic valvular endocarditis are similar to those of subacute bacterial endocarditis, but the course is more rapid. Fever is almost always present initially, and patients appear toxic, sometimes septic shock develops. Heart murmur is present initially in about 50 to 80% and eventually in more than 90%. Rarely, purulent meningitis occurs. So about diagnosis, right-sided endocarditis, septic pulmonary emboli may cause cough, pleuric chest pain, and sometimes hemoptysis. A murmur of tricuspid regurgitation is typical. So, diagnosis: blood cultures, echocardiography, and sometimes other imaging modalities, visualization techniques, clinical criteria. Because symptoms and signs are non-specific, vary greatly, and may develop insidiously. The diagnosis requires a high index of suspicion. Endocarditis should be suspected in patients with fever and no obvious source of infection, particularly if a heart murmur is present. Suspicion of endocarditis should be very high in blood cultures and positive in patients who have a history of a heart valve disorder, who have had certain recent invasive procedures, or who abuse intravenous drugs. Patients with documented bacteremia should be examined thoroughly and repeatedly for new valvular murmurs and signs of emboli. Other than positive blood cultures, there are no specific laboratory findings. Established infections often cause an normocytic, normochromic anemia, elevated white blood cell count, increased erythrocyte sedimentation rate, increased immunoglobulin levels, and the presence of circulating immune complexes and rheumatoid factor. But these findings are not diagnostically helpful. Urinalysis often show microscopic hematuria, and occasionally red blood cells cause puria or bacteriuria. Okay, identification of organisms. And the identification of all the organisms is an microbial is vital to guide treatment. Antimicrobial susceptibility. If endocarditis is suspected, 3 blood samples for culture, 20 milliliters each, should be obtained within 24 hours. If presentation suggests acute bacterial endocarditis, 2 cultures within the first 1 to 2 hours. Each set of cultures should be obtained from a separate, fresh venipuncture site that is not from pre-existing vascular catheters. Blood cultures do not need to be done during chills or fever because most patients have continuous bacteremia. When endocarditis is present and no prior antibiotic therapy was given, all 3 blood cultures usually are positive because the bacteremia is continuous. At least 1 culture is positive in 99%. Premature use of empiric antibiotic therapy should be avoided in patients with acquired or congenital valvular or shunt lesions to avoid culture negative endocarditis. If prior antimicrobial therapy was given, blood cultures should still be obtained, but results may be negative. Blood cultures may require 3 to 4 weeks of incubation for certain organisms. However, some proprietary automated culture monitoring systems can identify positive culture within a week. Other organisms, for example Aspergillus, may not produce positive culture. Some organisms, for example Coxiella burnetsi, Bartonella species, Chlamydia psittaci, Brucella species, require serodiagnosis. Other, for example Legionella pneumonia, requires special culture media or polymerase chain reaction. PCR, polymerase chain reaction, for example, Tropherima wypeli. Negative blood culture results may indicate suspicion due to prior antimicrobial therapy, infection with organisms that do not grow in standard culture media, or another diagnosis, for example, non-infective endocarditis, endocarditis, atrial myxoma with embolic phenomena, vasculitis. So, imaging studies, echocardiography, typically transthoracic rather than transesophageal, should be done initially. So, esophageal is more sensitive, transesophageal. For example, that is capable or revealing vegetations too small to be seen in classic transthoracic echocardiography. So, transesophageal echocardiography should be done when patients have a prosthetic valve. Transthoracic echocardiogram is non-diagnostic. Diagnosis of infective endocarditis has been established clinically done to detect perforations, abscesses, and fistulas. Computed tomography is used occasionally when transesophageal echocardiography fails to fully define paravalvular abscesses and for detection of mycothic aneurysms. Positron emission tomography scanning is an emerging tool for the diagnosis of endocarditis originating in prosthetic and intracardiac devices. Computer tomography and PET, positron emission tomography abnormalities, are now included as a major criteria in the European guidelines. So, diagnostic criteria. Infective endocarditis is definitively diagnosed when microorganisms are seen histologically in or cultured form, endocardial vegetations obtained during cardiac surgery, embolectomy, or autopsy. Because vegetations are not usually available for examination, there are various clinical criteria for establishing a diagnosis. They include the revised Duke criteria and the European Society of Cardiology modified criteria. So the European Society Cardiology criteria, it's my cardiac Society of Cardiology. So criteria are similar to the modified Duke criteria, but include expand imaging results as a major criteria as follows: vegetation, abscess, pseudoaneurysm, intracardiac fistula, valvular perforation or aneurysm, or new partial dehiscence of prosthetic valve identified by echocardiography. Abdominal activity around prosthetic valve implanted more than 3 months earlier, detected by PET or computed tomography or single photon emission computed tomography SPECT with radio-labeled leukocytes. Paravalvular lesions identified by cardiac computer tomography. The European Society of Cardiology differs from the modified Duke minor criteria by specifying that detecting silent vascular phenomena by imaging only is sufficient. Prognosis for infective endocarditis. Untreated infective endocarditis is always fatal. Even with treatment, death is more likely, and the prognosis is generally poor for older people and people who have infection with resistant organisms and underlying disorder, a long delay in treatment, aortic valve or multiple valve involvement, large vegetations, polymicrobial bacteremia, prosthetic valve infections, mycotic aneurysms, valve ring abscess. Major embolic events. Septic shock is more likely in patients with diabetes, acute renal insufficiency, Streptococcus aureus infection, vegetation size more than 15 millimeters, 15, and signs of persistent infection. The mortality rate for virulent streptococcal endocarditis without major complication is less than 10%, is virtually 100% for Aspergillus endocarditis after prosthetic valve surgery. So the prognosis is better with right-sided the left-sided endocarditis because tricuspid valve dysfunction is tolerated better, systematic embolism are absent, and right-sided Streptococcus aureus endocarditis responds better to antimicrobial therapy. So in conclusion,